Welcome and thank you to everyone for joining our 8th live webinar. Our intent with these webinars is to bring our community together to share critical information in these unprecedented times and to encourage dialogue, collaboration, and support for one another. As this is our 8th webinar, we are hosting with a new panel and moderator. We thank everyone in advance for understanding any technical or delivery challenges that may occur during the session. There continues to be a huge demand not only for information, but also for resources, human connection, and support. Please share with your colleagues who couldn't register that tonight's program is being recorded and will be posted on the CCS website. This webinar is an accredited group learning activity, Section 1, as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada, and approved by the Canadian Cardiovascular Society. You may claim a maximum of 1 hour. Tonight, we will be discussing a range of important topics and highlighting some key considerations and tips for treating patients with COVID-19. Immediately following the presentations, we will have a Q&A session. The question and answer period will be an opportunity for audience members to ask our panelists pressing questions and encourage constructive discussion among the faculty. Due to the limited time and the scope of the content, we will not be accepting or addressing any questions before the Q&A period begins. My name is Dr. Amar Jory, and I'm very happy to begin the session today. Next slide, please. So the objectives today are to summarize the value and indications for POCUS as the first-line imaging of patients with suspected or confirmed COVID-19 infection. Our second objective is to describe the application of point-of-care ultrasound during the pandemic in patients managed in a critical care and ward setting. Finally, our objective is to understand new approaches to incorporating POCUS into existing workflow. Next slide, please. Simply put, why should we conduct POCUS during the COVID-19 pandemic? Firstly, it helps triage the patient. Secondly, it helps determine the need for subsequent imaging. It reduces exposure of health personnel, and it helps reduce personal protective equipment use. Next slide, please. Dr. Mulvey, can you take away the second part of our session, please?
It's a pleasure, Dr. Jory, and it's really a pleasure to be here with this esteemed panel today. The rapid bedside assessment of the heart, chest, and vessels by point-of-care ultrasound has propelled this tool to the front lines of the fight against COVID-19 pandemic. Guidance documents have been released by both the Canadian and American Societies of Echo, outlining the role for POCUS as a tool which can be utilized by the attending physician, not only to obtain real-time information, but to help with management decisions in our COVID patients. The CSC released a general document which outlines particular features about the benefits, and it also cautions about some issues when using POCUS in confirmed or suspected COVID patients. Emphasized is that POCUS, especially when done with handheld devices performed by the attending physician at the patient's bedside, may be helpful in avoiding full transthoracic echocardiogram. It can triage or focus a subsequent transthoracic echo in the event that it's needed. As well, it can be utilized in on-call settings. The information obtained can be immediately integrated into the patient's care. That's the advantage of POCUS, as well as saving on extra saving on extra personal protective equipment by just having the one exposure to the patient and getting all the information at that time. If possible, saved images should ideally be archived, because this is really important to be able to subsequently review them to determine if there's comparison in serial studies that are needed, particularly if there is a change in the patient's status. And it's also helpful to review with a more expert individual, perhaps, or a colleague to see if there is a full echo that would be required or alternative imaging modality. Some systems using artificial intelligence technology can provide teleconsultative opportunities so that a non-expert user can actually be able to use POCUS at the bedside. The studies can be remotely uploaded, and you can actually have near real-time review or real-time review and guidance of image acquisition when using these types of telehealth platforms. And you're going to hear more about that from Dr. Jory. So it's important to remember that POCUS equipment is also subject to the same cleaning and disinfecting requirements as other equipment, but that logistically this can be somewhat easier because the devices are smaller. Next slide, please. The ASE document here is a workflow diagram that was suggested to be used. It's recognized that not all patients need that have COVID infection need to have a POCUS examination, but there was a suggestion as to how to approach this. If available and there's suspicion of cardiopulmonary abnormality requiring further evaluation, then POCUS can be the first line exam that is performed. And if it's performed by a trained operator, it's often the studies, the images that are acquired and the information is sufficient and that no additional imaging would be required. However, if there is a question or the operator does not feel confident about their information, then one would progress on to a formal transthoracic or alternative imaging modality as appropriate. Next slide, please. This is the American Society of Echo modified POCUS protocol for the cardiopulmonary assessment of patients with suspected or confirmed COVID-19. And it includes basic cardiac views that we are very familiar with, peristernal long and short axis views for LV and RV size and function, cursory valve assessment with color flow Doppler, evaluation for the presence of pericardial or pleural fluid. The apical views can also be helpful with ventricular and valvular assessments, while the subcostal views allow us to be able to assess the IVC for fluid volume status, as well as additional assessments for pericardial effusions. Lung views, which are new to many cardiologists, are integral to the assessment of the known or suspected COVID patient, and we're going to hear more about that. Vascular views may also be done to assess for DVT. Next slide, please. This table, which is taken again from the ASE document, lists specific cardiac POCUS findings and indications. Cardiac POCUS indications in COVID-19 patients include the following: for detection or characterization of pre-existing cardiovascular disease, for the early identification of worsening cardiac function, either due to known or pre-existing cardiovascular disease, or for developing cardiovascular complications with the COVID infection. Left ventricular systolic dysfunction, either global or regional, may be associated with myocarditis, stress-induced stress-induced cardiomyopathy patterns, such as in Takotsubo's, or epicardial or microvascular coronary thrombosis, i.e. good old coronary occlusion due to plaque rupture. Recently reported is a growing concern regarding right heart strain and associated complications. A dilated right ventricular finding appears to be associated with prognostic value for increased mortality. There was a recent publication from the Mount Sinai group on this just earlier this week. POCUS may also be able to assess changes in cardiac function over time, which is very helpful. It can allow for quick serial examinations, perhaps in lieu of heart and lung auscultation, which can be very difficult in a patient that is in a prone position or with surrounding ambient noise in an intensive care unit setting, or when you're wearing a PPE. Early reports suggest that myocarditis can occur in about 25% of patients, and this, of course, can become very complicated and progress onto a hemodynamic compromise. Plaque rupture and coronary syndromes, as I mentioned, it's very, very important to be able to differentiate regional and global changes that occur in the myocardial function. Pericardial effusions have also been reported, as mentioned, and you can detect all of these things with point-of-care ultrasound. Next slide, please. My last slide. So vascular POCUS is also something that we can do at the bedside. And this is very helpful, as mentioned, for not only for the assessment of volume status, but it also can be used for the placement of lines, et cetera. But in the patient with COVID in particular, there does appear to be an increased thromboembolic risk, and hypercoagulable states have been associated. So that the assessment of not only the inferior vena cava, but also moving more distally, an assessment of the leg veins can be very helpful to determine if there's DVT or not. Next slide. So, as I mentioned, lung ultrasound, which is also included in the basic examination at the bedside, is new to the cardiologist, and it is very important though. So I'm going to turn it over right now to Dr. Giamanish to be able to discuss this more in detail. Thank you.
Thank you, thank you, Dr. Mulvey. Next slide, please. So as cardiologists, we've been relatively slow to use lung ultrasound, and we sometimes joke that the lungs just get in the way of our cardiac windows. But in the next 5 minutes, I'll try to convince you that lung ultrasound is useful, practical, and it will improve your practice. So lung ultrasound is more accurate than auscultation and chest x-ray to diagnose common causes of respiratory failure. And it has the advantage of being portable, avoiding radiation, and providing immediate results. And as Dr. Mulvey described, it may also reduce the spread of COVID-19 infection within a hospital. So using an 8-zone protocol, which is shown on the left, 4 zones for each lung, you can perform an exam in a matter of minutes using the exact same equipment which you would do your cardiac POCUS with, and neighboring scanning zones. So lung ultrasound or ultrasound waves don't actually transmit through normal aerated lung. So the interpretation of lung ultrasound is based on characteristic normal and abnormal artifacts. So let's take a look at some examples. Next slide, please. These are both normal images. On the left, you'll see with a high frequency probe, at the top of the image, relatively fixed subcutaneous tissue. There are ribs on either side of the image, and below that you'll see a normal pleural line. So this is smooth, thin, and hyperechoic. And you can see that with respiration, there's some motion artifact as the visceral pleura slides along the parietal pleura. That's all normal. The image on the right is taken with a phased array probe, and I include this image to demonstrate A lines. So A lines are the horizontal hyperechoic artifact that are produced as a reverberation from the pleural line, and you can see they're actually spaced in intervals from the probe to pleural line. Next slide, please. So fluid-filled or thickened lung interstitium will produce vertical hyperechoic artifacts called B lines. B lines can be quantified, and they correlate with the degree of pulmonary congestion. So on the left, you'll see a patient with a viral pneumonia, and you can see the B lines that originate from the pleural line. They're quite discrete, and they extend all the way down to the bottom of the field. And in this case, they're irregularly spaced and accompanied by quite an irregular pleural line. You can see, I think the video stopped playing here, but if we can just cycle that again, you can see that it's thickened and in some portions appears somewhat shredded. So that irregular pleural line indicates an inflammatory or fibrotic process. And I'd just like you to compare that with an image on the right that's taken from a patient with heart failure who's congested. You can see there's a normal appearing pleural line, and now we see a lot of B lines. In fact, they're confluent or they've coalesced. So this indicates a greater degree of pulmonary congestion, and this would correlate with ground glass opacities on a CT scan. Next slide, please. Our next image is an example of a pneumothorax. You can see to the right of the image that while the pleural line appears normal, there's no motion artifact, which is highly abnormal. In the center of the screen, I've indicated where there's a lung point. So a lung point is the point where there's an abrupt cessation of lung sliding, and it indicates the transition from parenchymal to pleural air. So this is pathognomonic of a pneumothorax, and you can see how helpful this would be after a line insertion in a patient who has respiratory distress. Next slide, please. And this last example is of a pleural effusion. So a pleural effusion is visualized as this anechoic space around the lung. And you can see in this case that the lung resembles the liver. So we term this hepatized lung, and it indicates a lung consolidation. You can see throughout the lung, there's these punctate hyperechoic areas, and those are bronchograms that we're visualizing. Next slide, please. So it's important to recognize that the lung ultrasound findings associated with COVID-19 are non-specific, and they depend on disease severity. So they can range from a mild interstitial syndrome to dense bilateral consolidations. But it's also worth noting that lung abnormalities can actually precede our ability to detect COVID by PCR. So in a patient in whom you suspect a COVID-19 infection whose initial PCR is negative, you might perform a lung ultrasound to demonstrate findings that are compatible with COVID infection or identify an alternate cause of the respiratory failure. And this would prompt you to maintain infectious precautions and pursue further diagnostics. If you're interested in learning more, I've just cited a resource in the bottom here, which is freely available in the CJC. And with that, I'll turn it over. Thank you.
Excellent. Thank you. Thank you for the opportunity to be part of this panel. I'm extremely happy and delighted to talk about POCUS as it applies to internal medicine. And what are some of the challenges that we face as we're assessing ward patients that have COVID or have suspected COVID. Next slide, please. I'm going to start out with a case. So this is a 60-year-old gentleman who was admitted to the internal medicine ward with COVID and possible encephalopathy. He has a history of hypertension and type 2 diabetes. And essentially on day 3 of his admission, which is approximately day 10 of his symptoms, I got paged. Prior to that, he was on 3 liters of oxygen only. And the day that I got paged, he was starting to need 7 liters of oxygen. And quite, a lot of us have had similar experience with COVID patients is that they're actually entirely asymptomatic and they feel, at least in his case, he felt quite well. Next slide, please. So what you have here are his admission chest X-ray, which was relatively unremarkable aside from some basilar atelectasis. On the right, you'll see his chest CT, which did demonstrate some peripheral ground glass opacities, and he was ultimately swab positive for COVID as well. Next slide, please. So when I got called about a patient such as that, what I wanted to illustrate is what we used to take for granted, the history, physical imaging, everything is now that much harder. So for one, we're often examining patients with severe hypoxemia. They may or may not be encephalopathic. And some of our patients may have hearing impairment, and then I come in looking like that with a mask. There's no way they can lip read. And then on top of it, those who have tried percussing, looking for air fluid levels with ill-fitting gloves on, will probably remember what a horrible experience that is and how suboptimal that exam is. Next slide, please. So instead of relying on our suboptimal history and physical, I'm not saying we don't do it, but recognizing that there are limitations to it, I can now walk in and assess this patient. So on the top left is this anterior lung, and all it shows is a tiny bit of minor irregularity in a single B line, not that impressive anteriorly. On the top right is this posterior lung, which has a few more B lines. It's not a clip, it's a still, so you can't really see it. And at the posterior aspect of his lung, there was some subpleural consolidation. But I can also see that his IVC was relatively normal. And then the bottom right with the spine sign, was able to rule out any significant pleural effusions. His cardiac views show that his heart was hyperdynamic with no pericardial effusion. And for whatever it's worth, on the right side here, you'll see the portable chest X-ray, which was entirely unhelpful. It shows some atelectasis, and that's really about it. So really, in my under 10 minutes of assessing this patient, I was able to rule out pneumothorax. I was also able to rule out a significant component of heart failure, pericardial effusion. It allowed me to walk away thinking that I'm not going to need to drain anything out of him overnight. And that's certainly something that I wasn't able to do confidently before POCUS. Next slide, please. As you know, in internal medicine, many of our patients have multi-system disorders. They have underlying cardiac and pulmonary disease. They may have cirrhosis. They may have chronic kidney disease. Some of these come in without COVID, but they are suspected to have COVID. Some of them ended up having COVID, and COVID itself can exacerbate any of these particular organ systems, which makes assessment quite challenging. Next slide, please. So the top panel is a patient with mild shortness of breath waiting to rule out a PE. He had negative Dopplers of his legs, at least from a point of care perspective. In looking at his internal jugular vein, which you see in the longitudinal view on the top left and the transverse view on the top right, seeing that filling defect allows me to have a much more informed conversation with my patient about starting empiric anticoagulation. So that allows us to actually arrive to the diagnosis much earlier. Bottom slide is a different patient with elevated creatinine. Many of our patients come in, it's either acute or chronic, or acute on chronic. We often don't know, and we often just give fluid, see how they respond. But at the bedside, if we're able to see on the bottom left, here's a very abnormal bladder with a Foley balloon in place, and very dilated ureters that are seen posterior to the bladder. And on the right-hand side is a kidney with at least moderate hydronephrosis. Rather than just waiting to see how he responds with his creatinine, I know something's very abnormal about this patient. This patient ended up having transitional cell carcinoma. So with POCUS, allows us to actually start managing and investigating these patients much earlier. Next slide, please. So what are the take-home messages? I think COVID really has introduced a lot of challenges in the way that we normally assess patients. POCUS gives us so much more valuable data than we used to have in the past. And we all hear this, beyond the pandemic, it's going to be a new normal. And I am here to argue that POCUS is the new normal. Next slide. And with that, I'm going to turn it over. Thank you.
Hi, I'm so happy and honored to be invited. Thanks to all the organizers and Canadian Cardiovascular Society. So I'm going to talk a little bit about POCUS in the ICU. So I think it's an unbelievable tool. There's so much solid information that you can get in such an incredibly short amount of time, about as much time as we're going to spend talking about it now. So ICU POCUS for me is part of daily rounds. And to be honest, that has not changed before and after COVID. It's just that I think the worth is even greater with COVID, given the limited number of, or the attempts that we do to limit exams, limit scans. We don't send these patients to radiology as much. So what do I use it for? Every day, everyone gets a quick volume assessment, which is a combined thing, but does involve looking at the heart, looking at the IVC, cardiovascular, the lungs. Omid gave us a really nice overview of where you can look at the lungs, and then some housekeeping things that we'll go over. Next slide, please. So volume-wise, I look in great deal at the IVC. Personally, I'm very fluid stingy. There's no maintenance fluids in my ICU, only targeted, and I use POCUS to find stop points. And sometimes, as you can see, we want to get to the bottom right, reverse points for fluids. Next slide, please. Cardiovascularly, I think this is where in the ICU it does become quite interesting. I think we have to focus quite a bit on the right ventricle. Obviously, having a severe pulmonary disease will involve, and mechanical ventilation will involve the right ventricle going through some hurt. And so, I look a lot at the RV to LV ratio, the TAPC, which everyone's familiar with. And there's actually a recent, I think a preprint paper that came out showing how just some RV dilation, was associated with less good outcomes in COVID patients. Looking at the left ventricle, that would be LV, because there, as Sharon had mentioned earlier, there is an association, at least in the early reporting, of fairly frequent myocarditis. We can't say we've seen anywhere near 25% in terms of at least global or LV, but there definitely is the odd LV dysfunction, which may or may not have been pre-existing, and is worth looking at. And of course, the IVC is a big part of looking at the cardiovascular system to make sure you don't have venous congestion, splanchnic overload, which is worth a lecture in and of itself. Next slide, please. Now the housekeeping, which is where maybe it comes out to be really practical. And there's one that I actually forgot to add there because it's less part of the daily rounds, but maybe part of when we've just intubated someone, and Omid mentioned lung sliding, and it's a quick thing to do to check that you've got lung sliding on both sides to make sure you don't have a main stem intubation. Otherwise, anyone renal dysfunction should have a KUB. Look at the kidneys for a quick rule out of hydronephrosis, which takes a grand total of 4 or 5 seconds on either side. Look at the bladder. Irene showed us a nice picture of a bladder with a Foley dysfunction. Looking at the lungs, how are they doing? Is there sliding on both sides? Pneumothorax that may have happened and gone unnoticed, as we're not x-raying these patients as much as we usually do. Effusions, is there something worth draining? It hasn't been really a big thing in the COVID patients, except for the odd ones. I've drained a couple so far. And also looking at clots, making sure, as Irene found in one of hers as well, that you don't have any DVTs, and there is an association with increased clotting. So that is something that in our institution we're working with the radiology department right now to set up a semi-regular, every other day maybe, or 3 times a week, just for them to go around and do a quick screen on femoral and axillary veins. We try to do it as much as possible. When we have enough residents, everyone gets it every day. And certainly when I'm in scanning, I will take a look. Next slide, please. Now there's what I think some of us will think of as POCUS Plus, the tools for advanced decision making. We work with the venous excess by ultrasound assessment, associated also with RV failure to rule out venous congestion. I'll use transcranial Doppler when there's clinical indications. I've been using even more RV OT Doppler than usual, looking at what's my pulmonary hypertension doing? Do I think it's pre-capillary versus post-capillary? Might my patients benefit from some inhaled vasodilators? That's a little bit next level of POCUS, but certainly not out of reach of any cardiology-based practitioner, and not out of reach for anyone who's willing to just put in some scanning time. Prone POCUS is definitely doable. I think we've got a picture coming up. The views may be a little bit more limited, but still doable, and certainly the lungs are fantastic. You actually have more lungs that way than you usually do. And sometimes the use of TE when you've got some either prone patient that you can't get views on, or sometimes just the physiognomy of the patients makes surface very difficult. We had one who had some pneumonia and edema. Views were impossible, and TE was the way to go. Next slide, please. Quickly go through a little flash of the VEXUS. This is something that the group of Henri Deneau at the Institute's been working on for quite some time. We kind of put together a little classification which includes several of the Doppler views, all based, you can see it on the right there, the VEXUS C is the one who ended up being selected as we had assessed a whole cohort of post-op cardiac patients as the VEXUS pattern that was the most significant. Starts off with having a plethoric IVC. Once the IVC is plethoric, the pressure essentially distributes across the venous system, and you can start seeing abnormalities, as we can see there on the screen, across the hepatic vein Doppler, the portal vein Doppler, and an even intrarenal venous Doppler. And these abnormalities are of worsening grades as we go along here towards the right. And essentially, for instance, a portal vein Doppler will go from being a smooth flow to a very pulsatile flow. And at that point, that degree of splanchnic venous congestion correlates with a number of things, some things as yet unpublished and put out, but post-op deliriums, time to extubation, all these things are affected. But the one that was really well studied was the development of acute kidney injury. A VEXUS 3, meaning if you had a plethoric IVC and severe abnormalities, had a likelihood ratio of more than 6 to develop AKI. Next, please. A quick case had a young fellow who had a prolonged arrest, and as part of my post-arrest, did transcranial Doppler. Transcranial Doppler here showed nicely that we had no diastolic flow, and in fact, a little bit of a rebound flow. So anyone who does any Doppler can know, and anyone who's familiar with cerebral perfusion knows that we need to have diastolic cerebral perfusion pressure, and we had none here. Next slide, I think will show that he had a, sorry, I think we lost a slide around there, but we rapidly went to scan with that patient and found terrible, terrible cerebral edema. Here's just a quick few pictures of RVOT Doppler showing a nice ellipse, a completely normal RVOT Doppler, progressing here to a slightly sharper upstroke and slower downslope. Abnormal. As you go on, these are more and more abnormal patterns which may help guide your therapy from the standpoint of pulmonary vasculature. Next slide, please. And that's just an example of prone POCUS being all geared up, and it's still doable. Next, please. Just images of TE, which is sometimes the only way to get some good images in the prone patients. Next, please. Thank you very much.
Yeah, you should hear me now. Okay, sorry. So my name is Martin Albert. I'm a critical care physician at the Hôpital du Sacré-Cœur. I'm the intensive care program director at the University of Montreal, and I'm pleased to participate in that interesting meeting. Actually, we'll go over the next few slides to just a little case we had actually at the beginning of the pandemic. About 2 months ago, we got a 58-year-old patient in the emergency room who presented himself with 6 days, almost a week, of a flu-like symptoms, fever, cough, and myalgia. Actually, when he first arrived in the ER, he was not doing very well. He was tachypneic. He had an O2 sat of 78%, but he was stable at that time hemodynamically. So rapidly, the emergency physician decided to process to an intubation in the emergency room. And actually, we have been called about a few minutes later because right after the intubation, the O2 sat was quite low at around 70%, and the patient was becoming unstable with a low blood pressure. Obviously, we did rush to the emergency room to try to help the emergency physician. But arriving in the negative pressure room, it's quite obvious that without stethoscope, without X-ray, the process is a little bit more complex when you face such patient. So next slide, please. The X-ray of the patient initially did show multiple infiltrate, which in that time at the beginning of the pandemic was obviously compatible with the COVID-19 patient. Next slide. So I'll try to go through a simple 3-steps process with you over the next few slides just to show you how POCUS actually could help to help you to guide your decision in such case. So the first thing is to try to confirm the endotracheal intubation with the ultrasound. I'll show you how to do so. Secondly, to confirm the bilateral sliding lung as previously demonstrated. And thirdly, to go an overview of the diaphragm motion just to be sure that everything is moving on both sides. So next slide, please. The first thing, so obviously, is to take a regular vascular linear array probe and to put in the suprasternal notch as shown here on the slide. You should get what we see on the upper part of the slide. Actually, you see the trachea, the black hole on the upper part of the slide with in blue the cartilage that did create a bit of a posterior shadowing that you see on the ultrasound. You see in purple the esophagus that you may observe with the ultrasound, and the red obviously is the carotid artery. So what you're looking for is you're looking for the tube going through the trachea. So you should observe in the area behind the blue cartilage something moving. If you move the tube, you should observe that the balloon is there. You'll find the acoustic abnormalities associated with the balloon. And what you're looking for also is on the lower part of the slide, you're looking for what we call a double track sign, which is the you see as the red arrow show. It's the same abnormalities that you may observe with the cartilage in the trachea, but you'll observe it in the esophagus, which is quite abnormal, and actually is confirming that the endotracheal tube is actually in the esophagus. So that's what you were looking for, both to see if the endotracheal tube is in the trachea and to be sure that it's not in the esophagus. And actually, I did put a web link over there to the American College of Emergency Physicians, which is a quite nice section with videos and everything to go through that process to be more demonstrative. So that's the first step to be done. And next slide, please. Second step is to go through the same process that we did talk about a few slides earlier. So it's to try to see if there is some sliding on both sides and to be sure that there is no pneumothorax, to try to observe if there is any long point, if you're lucky, to confirm that there is a pneumothorax and to be sure that there is no absent sliding lung on one side. Next slide. You see here on the right side of the slide, the third step is to try to observe the motion of the diaphragm. So either by using a phasor or curvilinear probe and to put it in mid clavicular or in the lateral area to try to see the motion in hem mode, as you see here, to observe the motion of the diaphragm on both sides. So if we go back to our patient on the left, actually initially was quite difficult to see the tube. There was nothing in the esophagus, obviously. We were not sure, but we did observe something moving in the trachea, but we didn't see the usual balloon that we see with the endotracheal intubation in the proximal trachea. There was some normal sliding lung on the right and minimal sliding lung on the left. And actually looking at the diaphragm, we did see the normal motion of the diaphragm on the right and no excursion on the left. So the diagnosis was made of a right main bronchus intubation that explained why the patient was doing so poorly. And actually, interestingly, going back to the case, initially when we first arrived, the end-tidal CO2 was quite low in such patient because of the hemodynamic instability, obviously, and quite fastly after the tube replacement, the CO2 did improve quite much to up to a normal level after that. So it's quite a simple process, and actually has been numerous publications on such approach, and the sensitivity and the specificity of such approach is close to 95%. So that's quite good and useful when you're naked in the room with such patients. It's quite useful to have a POCUS to help you to go through such process. Next slide.
Thank you very much to our panelists so far. I'm going to just talk about the last section of our presentation today. We've heard from a number of our speakers using point-of-care ultrasound in various settings. For example, Dr. Ma talked about its utility in the physical examination. Doctors Mulvey and Kemenesh talked about the importance of point-of-care ultrasound for the cardiopulmonary assessment. And then we heard from Dr. Philippe Rolla and Dr. Martin Albert about the importance of point-of-care ultrasound for procedural guidance as well as advanced assessment, such as hemodynamic assessment in critical care. And so what this tells us is there's a spectrum of point-of-care ultrasound usage that we need to keep in mind. And for us to traverse the spectrum requires collaboration amongst the multiple disciplines that are interested in point-of-care ultrasound. So collaboration between the Canadian Cardiovascular Society, the Canadian Society of Echo, and the Canadian Critical Care Society is very important for point-of-care ultrasound now and beyond the pandemic. There are some great resources that are available. The American Society of Echocardiography, for example, has cardiac modules on their website, which are free for learners. There's a point-of-care ultrasound journal, which takes cases from around the world in multiple fields, so not just cardiac and lung, but other types of point-of-care ultrasound application. And Dr. Philippe Rollet also has this very interesting blog called the Thinking Critical Care blog with cases. Next slide, please. And then finally, I want to talk to you about the Arctica study group. A number of our panelists who are here today are actually part of this new study, this new collaboration, which is the Accelerated Remote Cardiopulmonary Tele-POCUS implementation by Augmented Intelligence for COVID-19 assessment. And this was recently awarded the Canadian Cardiovascular Society Challenge for Canada initiative. So we're quite proud of this national initiative. Let me tell you a little bit about this. Next slide, please. So this is basically a hub and spoke model. And so you can see the little red circles indicate the hubs, a number of centers. For example, Calgary with Dr. Ma, Toronto with Dr. Kemenesh, Queen's University, and Halifax with Dr. Mulvey are going to be overseeing the training of physicians that attend COVID-19 units for preparedness. So this is to teach point of care ultrasound to these physicians that require these essential skills to take care of these patients. The way we're doing this is very interesting. We're going to be using live streaming technology to teach these physicians, not only to teach them virtually how to scan point of care ultrasound, but also to guide assessment and to provide ongoing expert consultation and continuous care. And then we're going one step further, and that's what the green lines represent. We're actually reaching out to geographically remote communities. These are communities that are normally not well resourced and do not get the attention they deserve, but they also have patients that need to have assessment by point of care ultrasound. So these hubs will be providing expert opinions by live streaming of point of care ultrasound, what we call telepocus, to these geographically remote sites. So we're quite excited. These are the initial centers, and we're hoping that this will expand and be a network of networks, a network of hub and spoke models across Canada. Next slide, please. And then finally, we're also collaborating with colleagues in China and the United States to create a global portal of point of care ultrasound images to create a machine learning module that will allow us to contribute to better risk prediction of patients that undergo point of care ultrasound assessment in Canada. Next slide, please. So I'm going to skip over this slide, but in summary, it just talks about how there are various types of point of care ultrasound applied in different settings. In terms of the final summary for our seminar today, I want to mention that the American Society of Echo, working with partners such as the Canadian Society of Echo, has developed a very useful statement on point of care ultrasound during the pandemic, which was presented by Dr. Mulvey in detail. So I would recommend you looking at this statement. Then I also want to bring out the point that cardiologists should learn both lung and vascular point of care ultrasound. And Dr. Omid Kamianesh really did a nice summary of lung ultrasound for us. Then we heard from Dr. Ma and Dr. Rolla about how POCUS is integral to internal medicine and intensive care practice. And finally, we heard a little bit about how POCUS can be integrated with conventional imaging and is likely the new normal beyond the pandemic. And so that's why we entitled this seminar, The New Dawn. Thank you, everyone. So we'll move to Dr. Mulvey, who will help us navigate through our questions today.
You know, I just first want to thank our excellent presentations from all of our panelists. So thank you very much. This is really an exciting field to be involved in. And we've got some great questions coming in, and we'd encourage you all in the audience to, you're sticking with us, which is wonderful, and to please ask more. The first one I'm going to direct to Dr. Rolla. And it comes from Dr. Harry Kalagara, who's quite active in POCUS Twitter. Can lung ultrasound be useful in determining PEEP effectiveness in ventilated COVID-19 patients, as they already have pre-existing B lines? So that's a pretty focused critical care question. Can you give us a quick insight into that, Philippe?
Sure. I'm not sure would be the honest answer. Definitely you can see B lines disappear if you.
We lost your audio. Did we lose your audio?
Yeah, I would just move on, Sharon. Yep.
Okay.
Do you want to see if Dr. Albert has any comments on that?
Yeah. Well, Martin, would you help us with that? It seems like Philippe's having problems with his audio.
It's quite a complicated question, actually. So actually what we can see is if we observe with the POCUS ultrasound, we may observe the effect of the PEEP on the lung. We may observe what we think is the best PEEP based on the ultrasound examination, but that does not necessarily translate in increase or improve clinical outcome. So we're not there yet. So it's still a research tool, actually, regarding the level of PEEP, I would say.
Thank you. So now we're going to get back to something that cardiologists are maybe a little bit more familiar with or could manage. And this question comes from Dr. Robert Moss. Should venous assessment for DVT be in the cardiologist's repertoire? And I would like you to take a stab at that, please, Dr. Ma.
It's very challenging for me as an internist to say what cardiologists should do. So I don't know that that's totally fair, but I can tell you that as an internist, it's not hard to assess for the presence of DVT in any of the vessels, to be honest. It's not a difficult exam. What is difficult is doing a complete exam. So if you see the findings of DVT, which is easy to do, you have the diagnosis, but it's harder, at least as an internist, for me to rule out to DVT. So I'm not going to spend 20 minutes really digging at 1 centimeter per through the entire vein. But it's extremely helpful when you do see the clot. So I would say it's an easy task to learn. You guys have already, cardiologists already have the skills and the understanding of Doppler. I would say go for it. It takes very little time, gives you so much information.
I would just like to add something to that, Dr. Malve, if that's all right.
Yes, I was just going to ask you to, actually. So,
yeah,
yes.
so the hospitalists have developed a protocol called the 2-point compression protocol for looking for DVT, and there's also a 3-point compression. And so there's some good literature showing good accuracy and good pickup by hospitalists for DVT. And so our audience members can look up some of that literature. There's one interesting study called POCUS, which with the HO stands for hospitalist oriented point of care ultrasound looking at DVT. So it's an interesting study. And there has been a meta-analysis showing good pickup by hospitalists. The American Society of Echo CAVUS Council, so the Circulation and Vascular Ultrasound Council, did confer on this. And their advice was that in the case that a sonographer is not available and you are in a COVID-19 unit and you are skilled in this technique, then it's certainly reasonable to look for DVT. You know, sonographers sometimes can get in and quickly take a look at this, but if they're not available and you have the skills, then it's a reasonable protocol to follow.
Thank you, Dr. Jory. I have a question now for Dr. Kiamanish, and this is involving lung ultrasound, again from Dr. Kalagara. With pleural abnormalities being more common in the COVID-19 era, are we able to differentiate lung sliding and lung point? Is there enough reliability in these signs to be able to diagnose pneumothorax? So lung point and lung sliding and the diagnosis of pneumothorax, just quickly, because this is a critical care, important question.
Yeah, so I think with an inflammatory process or fibrotic process, you can see a reduction in lung sliding, but to actually demonstrate a lung point, I believe would still be pathognomonic for a pneumothorax. I hope that answers their question.
Yeah. Would our critical care docs there agree with that? Martin, Philippe, would you like to weigh in?
Yes, we agree. I agree at least. Yeah, a long point is pathognomonic. Okay,
that's great. So we have another question here, and I think it's very important question, and it's got to do with is there? I think I'll direct it to Dr. Jory. Is there a danger in point of care ultrasound in missing findings that could otherwise perhaps be determined in another way? So what's your thinking on that?
I love this question. I think it's very important. So I've been teaching point of care ultrasound for several years. We teach medical students, and we've been teaching internal medicine residents point of care ultrasound. And one of the things we always mention is that just because you see something or just because you don't see something, it doesn't mean it's not there. And so I think learners and people who are applying point of care ultrasound really have to understand that they could be missing findings and not serving the patient well in some situations. So just because you don't see something doesn't mean it's not there. And sometimes you do have to collaborate and integrate your workflow with the echo lab. The other issue is that we have looked at a peer-to-peer teaching model, and in fact, we did find that there was an increase in false positives as well in some cases. So we did study that. And with the application of point-of-care ultrasound, there was more confidence in a misdiagnosis. So that study was published actually in the Canadian Journal of Cardiology. The first author is Wilkinson, who was my trainee at that time. And so it does show that there can be some false confidence as well with the application of point of care ultrasound. That's why I think continuous quality control is important. I think documentation is important. There is some debate about archiving and image storage, which helps with ongoing quality control. So I think those issues we don't have time necessarily to get into, but there are things that need to be taken into consideration. Whenever a tool is powerful and effective, it has to be applied with responsibility.
Thank you, Dr. Jory. That was a pretty comprehensive answer. Now, this is a simple question, but it's a complicated answer. And I would like to actually ask each of our panelists, because they're representing different disciplines, about billing. And I think that the situation is a little bit different in the critical care area versus how we might do it in internal medicine or in cardiology. So just a quick yes or no answer. Do you bill, Dr. Rolla, for the POCUS examination? No, he's shaking his head. Okay. And how about you, Dr. Albert? Do you bill for the POCUS examination?
Very rarely.
Very rarely. Okay. And Dr. Ma in internal medicine? No, it's part of your comprehensive evaluation. And Dr. Jory?
No, I use it sort of more to enhance my physical examination.
So to integrate it into the complete package. How about you, Dr. Kiamanish? What are you doing in Toronto?
No, we don't bill for point of care ultrasound.
Okay, thank you. The next question is with respect to details on optimization of probe choice, particularly for lung ultrasound. Maybe Dr. Kiamanish, would you like to take a stab at that first? The difference between using a phased array probe, a linear probe, which do you use, and in which situations?
Sure, I think it depends on what your suspected pathology is or what you're trying to demonstrate, and also what's available. So most cardiologists will have a phased array probe available, and a lot of the handheld devices that we're using now have that. So I would advocate for that. A phased array probe will also give you the depth needed to demonstrate B lines. So you want to get at least sort of 18 centimeters of depth to make sure they are B lines that you're visualizing. So I think that's a great tool. If you're looking at more superficial structures, or you want better spatial resolution of the pleural line, then a high frequency probe, if available, would be another option.
So for example, if you wanted to evaluate for a pneumothorax and skip the chest x-ray, and there was a question relating to the sensitivity too of that, if you used a high frequency probe, a linear probe, that would be your choice, and is that sufficient? Do you still need to do a chest x-ray?
Well, I think that's an interesting question. The lung ultrasound outperforms the chest x-ray, but I think, you know, for medical legal documentation purposes, that might depend on an individual's personal practice, but strictly speaking, no, the lung ultrasound outperforms the chest x-ray for sensitivity and specificity, particularly if you're able to demonstrate a lung point. Should also note that some of the handheld devices will offer you both a linear probe as well as a phased array probe. So if you are venturing out into POCUS beyond the heart, that might be a consideration.
Thank you. And in the critical care arena, do you do a confirmatory chest x-ray if you have diagnosed a pneumothorax by lung ultrasound? Dr. Rolla, do you feel that's necessary or not?
It may not be necessary, but it could be useful. For instance, if you want to know that, because we can't necessarily, unless we get a really close, a very proximal lung point, we don't know the size. So if you might be considering inserting, you know, a needle tube thoracostomy, you might want to know that it's a big one versus a small one. So it could be useful, but it's not necessary to make the diagnosis.
Okay. And I think we have time for 2 more quick questions. These are great critical care questions. Thank you. How does your approach to lung ultrasound change with a ventilated patient? And you know, this is something that we always talk about, particularly like for the VEXAS exam, the IVC. How do you approach that? Maybe Martin, if you could address that question, please. How does your approach to lung ultrasound change with a patient on event?
Yeah, actually, what is very important is to be conscious of the fact that the variation in pleural pressure and related to the ventilated pressure are the most important predictors of what's going on with the vascular performance of the test. So I would be very careful to interpret such tests if you don't know exactly what type of ventilation you use. So it's very important. So it's the key, I guess, about the.
Thank you very much. And one last intensivist question here. And I think maybe Martin, if you could address this too. Do you routinely do RVOT VTI as part of the VEXAS scan grading? Or just the IVC scan? Do you always do the RVOT outflow? Maybe actually Dr. Rolla, would you like to address that?
Sure. As part of VEXAS, no. VEXAS, we're really looking at splanchnic, so IVC down, just look at splanchnic congestion. I don't do RVOT VTI regularly. I do RVOT Doppler fairly regularly, paired together with my RV to LV and RV function to kind of make therapeutic decisions, though. So I'll do that fairly frequently.
Thank you. And
all right.
I think that has covered an excellent spectrum of applications of point-of-care ultrasound in the beyond just the COVID patient, but particularly as we're learning more in the critical care arena. And thank you very much for your answers. Amr.
Thank you so much, Dr. Mulvey, for navigating through those questions. And thank you to all of our panelists for your comprehensive answers. I love this group It was very multidisciplinary, and it was wonderful to hear how you apply point of care ultrasound across the spectrum. So we've only basically scratched the surface of POCUS. I think there's a lot more to talk about, a lot more issues. So for the audience members, please reach out to us via social media or email us, and we hope to interact with you a lot more about this interesting topic. Please fill out the exit survey at the end of the webinar to receive your certificate of completion to claim your credits. And as I mentioned, tonight's program will be recorded and posted on the CCS website very soon. When it becomes available, please share it. And I would just like to say thank you to all of our panelists once again. Good night to everybody. Keep well, stay healthy, and please stay connected with us. Thank you.
Bye. See ya.